forgot to start the recorder, so I'm doing that now. And then, no, I don't want to use that, so I'm going to unshare this. This is not my whiteboard. This is a different whiteboard. There we go. Okay, so let me get the right pen. That would be helpful. Move that. Get my brush. There. So here, you know, usually, so these are signs and symptoms. So usually they're asymptomatic, so there's no symptoms, but you would probably hear, you know, an actual murmur. That would, when I mean by asymptomatic, there's no outwardly signs or symptoms. But other things you could see would be chest pain at rest, and it's usually described as being sharp, right? They could be fatigued. They could have syncope, which is basically fainting. Short of breath, so they could have dyspnea. Or palpitations, just like they really feel their heart beating. So if they have dyspnea, they can actually have, you know, difficulty lying flat. What is that known as? What is a difficult?
Orthopnea.
Orthopnea. So it's basically they experience shortness of breath while lying supine, is how that would go. So your patients may, when you actually do your assessment, so you may hear a murmur. And what's a murmur? If you had to describe that to somebody, what would a murmur? A swishing sound, swooshing sound, but what does it represent though?
Backflow, correct? Or is it ineffective closure of a valve?
Is it ineffective closure? Because there's folks that actually have heart murmurs that kind of work out. So, you know, their heart rate's a little bit slower, but they don't have mitral valve prolapse though. It's kind of like turbulent blood flow. But it does make that swooshing sound. So it's more like a, instead of a lub dub, it's like a lub dup, right? So, oops, that's not what I wanted to do. I wanted to go there, but just write that this was like more of a swooshing sound or a, you know, swishing sound, but it's definitely kind of noisy. So, you know, there's turbulence in the blood flow itself. So when you're auscultating, the sound that it's going to make, instead of, this is what happens when you have 70 things right in front of your little keyboard. So the sound of the heart would be more like a lub dup versus a lub dub. So it's a little bit more harsh. And that's what happens as the heart valves are closing, okay? So besides that murmur, the patient could, you know, have changes in blood pressure. So the medical sign for changes is a triangle. So they can have changes in BP, meaning orthostatic hypotension. Okay. What tests can we do to identify?
Yeah, echocardiogram.
Echocardiogram would be perfect. I've had one of those. So we could do an echo. And what that's going to look at is, how does the blood move? Does it, do you end up getting that atrial kick, which would mean that your sinus node, your SA node is working really well, and you're getting that blood flow being pushed forward into the pulmonary artery. So it's going to look at the leaflets of the valves. It's going to look at how they close, how they open, look at if there's any thickening. So that's usually something you may, if they have mitral valve prolapse, then they'll see thickening of the leaflets. They see regurgitation. So backflow of the blood, instead of moving forward, it'd be moving backwards. Okay. And is that our hallmark diagnostic tool? The echocardiogram?
I'd say so.
Yep, that is. That's our hallmark. You can do an ECG, and with ECG, you would be looking for whether they have atrial dysrhythmias, ventricular dysrhythmias, or non-specific ST segment or T wave changes. But you can have those T wave changes and ST changes with other things as well. So, that may not be your tell-all be-all. One other thing they may use is a Halter monitor. What is that?
You wear a monitor around your neck.
Mm-hmm. What kind of monitor is it?
A heart monitor.
It is a heart monitor. So it's basically just like an EKG. So it's a heart monitor that you'll wear, and they're going to be looking for any type of dysrhythmias. Okay. With your non-classic, there may not be any specific treatment to do, but just to monitor it on a regular basis every 3 to 5 years, get that echocardiogram done. If they're smoking, we're going to say, hey, you need to cut that, modify your lifestyle. So things that could be a reason as to why the patients are having some difficulty. When we look back at causes, we talked about things like exercise intolerance, stroke, heart failure. So, you would have to go back and think of what put patients at risk for developing a stroke. High blood pressure, right? Clogged arteries from plaque, so cholesterol and calcium buildup in the arterial system and actually the venous system as well. So when you have coronary artery disease, that affects all vessels, no matter where they are. So what else would make the vessels kind of like narrowed would be your diabetes. So this is why they're, when they're doing their treatments, they're looking at some of these modifications that can be done. So these are diagnostic tools. And then we have, our treatment, which could be, dietary modifications. Some say dietary changes. Stop smoking if that's the issue, and drinking, because drinking causes vasoconstriction. We can look at decreasing stress. Why would stress play a factor? Or how would it?
Causes vasoconstriction, ultimately hypertension.
Exactly. That vasoconstriction is definitely, again, poor perfusion going through. Okay. So that way, those would be the things that you would talk about. If it's high blood pressure, DASH diet. If it's, related to cholesterol, then we're talking about, more fruits and more vegetables, less organ meats, green leafy vegetables, less fat. So all of those things would, which we talked about in the beginning, would play a role here. Avoid alcohol, as I said before, or, decrease alcohol intake, stay hydrated, make sure that they exercise as tolerated. So basically, you know, there's that saying of no pain, no gain. Like you really have to go all out when you're exercising. You don't have to go all out. You just need to go to what your body can tolerate and what you can do. So don't introduce any undue fatigue that you don't really need to, you know, put into place. So let's go through why we would be using some of the medications of what we are using or are outlined to use. So let's look at meds. What meds could we recommend? This is part of still of our treatment. We talked about some of the non-pharm stuff. So here's the pharmacological.
So beta blockers?
Why beta blockers?
Slow down the heart rate, and then they'll help decrease any extra oxygen needed, so it could stop the palpitations and the pain.
Okay. Awesome. What else could we do?
An anticoagulant probably would be pretty good for it.
Anticoagulants would be perfect because remember, if that blood can't be moved forward, then that's going to be a problem. Because blood that doesn't move forward, it remains stagnant. And when blood sits, what happens when blood sits?
When blood stops moving and starts clotting.
Exactly. So blood it sits there and it just clots. And then now we have the risk of other things happening to the individual, right? So we're kind of looking at, you know, why we use all of these different things. And they all make sense. We're going to slow the heart rate. We're going to decrease the blood pressure. But remember, we got to be careful because they may actually present with low BP or at least orthostatic hypotension, right? So we need to make sure that we are addressing those processes. So we're going to give the beta blockers for that. Is that a beta 1 or beta 2?
Beta 1.
Beta 1. So we're going to give it to also eliminate irregular rhythms or irregular heart rate. So we're going to increase the force of contract. This will not increase. This is going to decrease the force of contraction. So it's going to decrease the workload. That's what I wanted to say. So we're going to decrease the workload. We're not going to make it work any harder than what it needs to. And by doing so, this should actually increase blood flow. So it will also stop with the chest pain and the palpitations, the signs and symptoms related to that. I apologize for my email, but it's just a lot of stuff going on. Then we can give them like aspirin, and this will help to decrease clots or clot formation. Okay. What kind of medication is aspirin?
Antiplatelet.
It's an antiplatelet. So this is an antiplatelet, which basically means it doesn't allow the platelets to stick together and form clots, because we can also give them anticoagulants, you know, like Coumadin, Plavix, So they can be on those types of medications, okay? And especially if they have any type of neurologic deficits, we would give them the aspirin for that. Then we would consider some other things, maybe some things to decrease afterload. And what did we say afterload was last week? So it's the pressure that the left ventricle would have to overcome it would have to overcome the aortic pressure. So when you usually have mitral valve prolapse, your left ventricle is kind of weak because it's not being able to pump effectively as well. So to go out of the aorta, so it's going to work extra hard, which is the reason why we give them that beta blocker. So we're also going to look at, minimizing the heart from having to work extra. So like hydralazine or nitrates. And give me an example of a nitrate.
Viagra.
Say that again.
Viagra.
Is Viagra a nitrate?
Nitroglycerin. I mean, it can be used as a nitrate. I've seen it a couple times.
Oh, I thought you meant like not just medicines we give for heart stuff. I thought you meant like
I
all
wanted
nitrates.
I wanted to know, because your book talks about nitrates. So you need to know what nitrates are, which is literally nitroglycerin. And nitroglycerin is a what?
Dilator.
It's a vasodilator. So you would be looking at giving your patient some type of vasodilator, right?
Right.
And if you
I only mention it because I know that Viagra is a contraindication for nitroglycerin.
Exactly, and that's what I was like. It's a contraindication, but why?
Because if those nitrate-based medicines together can cause a precipitous drop in blood pressure that would be dangerous.
They're both vasodilators, which means vasodilation plus vasodilation is like double the vasodilation. So it's a synergistic, gives it a synergistic effect. So I mean, it's kind of saying the same thing, but just a little bit more. I'm just making it a little bit more clear. So I'm not, trying to complicate or say what you're saying is incorrect. I'm just adding the context to it. Definitely. So, we have those things that we would need to, utilize for individuals as far as medications. They can get surgery, which would have valve replacement. So that's do a mitral valve repair. So that's an option. Other complications from a prolapse would be migraines. It could be a stroke. It could be chest pain. They can end up, it's not like the angina, which we're going to talk about as well today, but those are things that your patients can also experience. But they're going to need to see a cardiologist to make sure that all things are good. If they have any infectious processes, then they're going to need antibiotics. That would be another part of their regimen, especially if it's the infective endocarditis or infective. Magnesium supplements, if the patient has a magnesium deficiency, or we can talk about foods that are high in magnesium, which was part of exam 3. So those are things that we want to, inform patients about. We already talked about things to avoid, like caffeine. So we add on here mag. We can give magnesium supplements. We talked about nitrates. Hydralazine, that also drops blood pressure and causes vasodilation. So those are things that can be done. So if they have mitral valve or mitral regurgitation, then they will end up having that mitral valve repair done. So we want to, make sure we talk to the patients, inform them what's going on, get their feedback, because, this surgery is not just some run-of-the-mill surgery. It's pretty significant. Talk about the medications that will probably be ordered, the cardiac monitor they'll probably be wearing post the surgery. They'll need those SCDs or anti-embolic stockings that they need to look at. Our role is making sure vital signs look good. So we're going to be checking the 3 positions, them supine, sitting up, and standing. That's how you check orthostatic blood pressures. We're going to see auscultate the heart tones, and we'll also, prior to surgery and then after surgery, because we should be hearing the click if they had the mitral valve repair done. what's their activity tolerance level? So we're going to start them slow and then have them build, have them cope with their situation, by if they don't need treatment, things that they need to do to promote rest and still not overdo it. So anything else you can think of with mitral valve prolapse? So if you were giving a patient, say for instance, they had they had a magnesium deficiency. And then your patient starts having, slower respirations, their deep tendon reflexes become absent, there's no ankle clonus. What would you be thinking you would need to do?
Give calcium gluconate.
Before that. So you're treating them with MAC. So they have a deficiency. We're treating them with magnesium.
Stop the mag.
Stop the MAG. That's the first thing. So we're going to stop the MAG, but first recognize that, okay, now we're moving into hypermagnesemia, and we could treat it with calcium gluconate. But before we get to the calcium gluconate, we at least need to stop the problem before that time. Does that make sense?
Yes.
Okay. Where is the location if you are going to assess for the mitral valve click or the regurg? Where would you listen? What intercostal space?
Third,
Don't guess, no.
3.5.
There is no such thing as a 3.5 intercostal space.
I'm going to go with third. No, fourth.
And then is that mid-clavicular? Is it substernal? Is it to the left or right of the sternal border?
It's on this. It's third clavicular on the sternal border on the left side.
Okay, do you guys agree?
Sure.
He could be blowing smoke. You guys are just like, I'm going with it. Why? I mean, what did you look at your video? What did your PowerPoint say? What did the Fox say?
Can you repeat the question?
So if you are going to see if your patient has a murmur, or if the patient has, you want to listen to see if they have a click, where would you auscultate to actually listen to the valves? So your excuse me, when you're looking at your valves, it is TPMA, toilet paper, my assets. But when you're listening to the valves, that becomes more like a Z pattern. So it's more like ape to man. So APTA. So AMT, ape to man. So ATMA. That's what I was trying to say. So it is on the left sternal border, but I'm asking, is it third, fourth intercostal space? Where is it? And that's where I'm asking when you're going to auscultate the valves.
I'm sticking with 3.
The third intercostal space?
He said third. I'm just seeing if anybody agrees or disagrees. So I have 2 3s. And this is where you would hear that mid-systolic click. Because that's what you would be looking for. And that mid-systolic, click, what does, that's letting us know where the deficit is, right? He says 3, I have 2 on 3.
I'm going to go with the 5th intercostal.
Okay. So I have a 3rd intercostal space. I mean, a 5th intercostal space. I'm so sorry. I didn't
Go with 4th.
Do you even believe what you're saying? This is too cute.
5th intercostal, left mid-clavicular.
Okay.
Fifth intercostal, left mid-clavicular, yeah.
So we have a mid-clavicular. And we have left sternal border.
Can I change my answer now? Because I think they're right.
Okay. I'm not saying who's right yet. So you're free to change.
So you're basically listening to the apex then.
Oh, well, yeah, I mean, would have been, it's
Yeah,
the
that'd be
left
the
side,
apex.
so it's probably more mid-clavicular anyway. But would it be apex or would it be higher up than the apex? Because the apex listening to the aortic valve, right?
So usually it's a Z pattern. So do you know what the Z pattern is? I mean, and maybe that's not making sense. Okay, so, oh, I had the wrong pen. Then I ended up doing something crazy. Hold on. Okay, so when you're talking about the Z pattern, so here is usually your 2nd intercostal space on the right? Then it goes across over here to the left. Then it goes down here and then over here. So that's your, so this is going to be about the 4th or 5th intercostal space mid-clavicular. This is the valve. This is the aortic. This is the pulmonic. This is where you auscultate, which is different. This is the tricuspid. And this is going to be the mitral. So that's why I was asking, is it 2nd? Is it 3rd? Is it on the sternal border? Is it mid-clavicular? Where is it? So I think based on that, we know that it's probably a little bit lower than the 3rd. We for sure know that it is mid-clavicular. So the question is, what does your book say? I think I've given you quite enough for you to now finish the rest of this so that you're not wagging it the whole way through.
So 4th intercostal, mid-clavicular.
Okay, who all agrees or disagree? Because if I tell you, you're not going to remember. And the reason being is because I keep telling it to you without you having to go look it up or know it for yourself. So I'm hoping that you've been looking at this material. So it's actually the 5th intercostal space, and I believe that was Mr. Don that said that earlier. Would that be correct, Mr. Don?
Yes.
Okay. So, just for your record, intercostal space, then clavicular. That's where you would auscultate. So the apex wouldn't be readily palpable for that. And I know you were trying to go with apex versus the base of the heart, but that's where you would find that information. Okay. All right. Now that we've pumped the brakes on that, I think now we can kind of move forward on where we stand. Ooh, somebody has a question. Hang on. Oh, it's not a question. All right. So tell me what you know about angina or angina, whichever one you want to use. I am okay with.
Like a heart pain that's typically precipitated by exercise. That's for stable angina that we're talking about.
All right, so first let's talk, angina is basically chest pain, right? Let's start with that. So we have angina, and this is chest pain. And no matter what, I'm just gonna spell out chest pain so no one thinks it's cerebral palsy. So you definitely have this, which is going to be a heavy pressure. What is the other descriptor that they'll give for this?
There's an elephant sitting on my chest.
So yeah, an elephant sitting on my chest. So it's a heavy pressure. So that's that one. What else? It's substernal, right?
It could radiate toward the left arm or jaw.
Okay, it can radiate to the left or the right, but let's just start with this piece here, because for sure it's going to be that. And then I'm going to say plus, not plus, plus greater than or equal to one of the following. Okay, so what usually may accompany that is radiation, and that would be to the neck, jaw, arm. Let me get to scroll it over there. Back or teeth. Okay. They can have nausea and or vomiting, diaphoresis, which is sweating, they'll be short of breath, so dyspnea, or they can have dizziness. So it's one or the other, but for sure we're going to have chest pain. Okay, and it could be in the the epigastric region. It could be, which is the reason why they say that it's in the epigastric region. So I'm gonna put epigastric here. Ooh, Christmas colors. That way you kind of understand that it can happen there, because it could feel like gas, right? Which is a lot of what they may complain of, just like a gas pain. And what we can ask them is, hey, did you take any antacids. And if the chest pain goes away, is that a heart attack? So that's a question for you guys. And the answer to that would be no. Some other things you want to find out about the chest pain. So this is to differentiate that this is actually angina. So just kind of, here's a little rule of thumb. So I'm just going to say, you know, rule of thumb here. If they have chest pain with inspiration, so when they breathe in, this is probably an upper respiratory or a lower respiratory infection like pneumonia. Okay. If the chest pain is reproducible, what do I mean by that? Like if
A
you
specific motion,
like
a specific motion or palpation can cause it in the same pain.
So if you move, so movement or palpation induces pain. That's the word I can use. Okay. Now, if you have chest pain with a burning sensation, this is probably gas or indigestion. Okay. Last but not least, chest pain that's shearing and tearing. What is this? It's very forceful. And what I mean, it comes on, that pain comes on and it doesn't abate, but it radiates to the back, radiates to
AAA.
Yes, to the back, more specifically the shoulder blades. Then this would be a thoracic, aortic aneurysm. Okay? So this is what I'm trying to get you to understand, that all chest pain does not equal a heart attack. So I've given you 4 clear examples where this would not be true. Okay? And there are others, but just, you know, we're just going to work with these for right now because I don't want to tax your brain with it. So this is our guiding principle here, that the angina, which is chest pain, and the reason why they're having this is because the patient actually has, at this time, ischemia, which is decreased O2 to the tissues, specifically the heart tissue. Okay? So that's the reason why we have that scenario working. So do you have this down? So you understand that, because I'm going to erase this sheet here, because now we're going to go to, I'm going to create some of it's going to still stay. So I'm going to just probably write it a little bit smaller. So we have, chest pain, that heavy pressure, kind of put this back over here, plus greater than or equal to 1 of the following. Ooh, Joe Carroll, the following. So we said radiation, diaphoresis, nausea, vomiting, dyspnea, dizziness. I think that was all that I had there. Would that be correct?
Yes.
Okay. So we have that. Now I'm going to This is our guiding principle. So we're going to talk about stable angina. And this is going to be unstable because there's two types. Okay. Well, first we're going to start with stable. With stable, the person has chest pain with exertion or activity. They're still going to complain of, greater than or equal to one sign or symptom. I'm just going to say to the left. Okay. When I'm talking about exertion, that could be sweeping, vacuuming, raking leaves, cutting the grass using a push mower, shoveling snow, gardening. Those are all types of things. Riding a bicycle. So somehow there was a stressor for which the vessels, the coronary arteries spasmed or got tighter because of clot or whatever the case is at the time. We don't know because we can't see internally. And now the patient started having some deficits. But the key is this happened on exertion. They're doing some activity, okay? So how do we treat it? Well, if things are happening, with exertion, then you know what? Let's just stop. So let's rest, okay? So we're gonna rest or have the patient rest, and we're gonna give them some oxygen. How much? And what kind of oxygen?
Mm, 2 liters.
Okay, what's going to be our choice of delivery? Are we going to do a face mask, non-rebreather, nasal cannula, bag valve mask? What are we going to use?
Nasal cannula.
So we're going to use a nasal cannula, 2 to 4 liters. And we're going to monitor O2 sats. Notice it's a SAT, not STAT. So we're going to monitor O2 saturation, and we don't want it, we don't want greater than 98%. Why? What happens when we try to get it all the way up to 100%?
The O2 saturation, as it goes higher, becomes a less reliable indicator of just how much PaO2 there is. And if very high levels of O2 are a vasoconstrictor.
Exactly. So if greater than 98%, we're going to now cause vasoconstriction or spasm, or vasospasms. And so now the patient, we're here trying to treat a person who already has a blocked artery or an artery that's already struggling and that's not getting nutrients distal. Now we're going to actually create another problem for the exact same coronary artery by trying to crank up the O2 sats by giving them a bunch of oxygen. Okay. All right. So next, besides oxygen, so we're going to do this. We're going to have them rest. Then we're going to give them nitroglycerin. And with nitroglycerin, we can give them the tabs. It'll be sublingual, 0.04 milligrams. Okay. Sublingual means under the tongue. They should feel a burning sensation. That's how you know it's potent. Okay. Now you may give IV nitro. It depends on what the physician ordered. You may give nitro paste, but at least know you're going to be given nitroglycerin of some sort, whether you're going to start a nitroglycerin drip or you're going to give nitroglycerin paste. So they may say you may give a half an inch to up to 2 inches, and you're going to put it on like wax paper and then place it on the patient's chest. But make sure that, you know, if that hairy monkey dude, then you need to shave that, because we need to make sure we get the absorption. Otherwise, it's going to be sliding all around. So clean that area. If they're sweaty, definitely dry the area off as well to make sure that you can get good coverage. Don't touch this with your bare hands, because it's absorbed through the skin, as we're talking about. And so you can now be giving yourself nitroglycerin. So that's why you want to have on a gloved hand. Try not to put your fingertips on people's medications. That, to me, that's gross. Your gloves are touching, you know, keyboards and stuff like that are usually not wiped off. So just food for thought. The other thing we want to make sure the patient receive is aspirin, 325 milligrams. And they may get 81 milligrams, either one, but 325 is the right to go. Now, this is PO, however, must be chewed and swallowed. So you don't have an option here, okay? The first one, they're gonna make the patient chew and swallow it. Why?
Much faster absorption.
Faster absorption, okay? There is a potential that you would then need to prepare for either the cath lab or prepare for TPA, so a thrombolytic to be given. So that in that cath lab, what's gonna happen there?
Like the whole process?
Well, not necessarily the whole process, but what is the patient actually, I mean, they're gonna go in and look for the where the blockage is, right?
Yeah.
The cath lab or the catheterization tells you where the location is and how blocked the artery is, okay? So when I say cath lab, let me just come over here to the side. I'm gonna put this in blue. So this would be a coronary, oops, not corn. You can tell I'm thinking about food. Coronary catheterization. The other word is PTCA. What is that? Percutaneous transluminal what?
Angioplasty.
Angioplasty.
Coronary angioplasty. And this could be with or without a stent. Okay, but they're going in to see what's going on. And this is, you notice I had that before the TPA. TPA, you have to be worried about, did they have head injury, this, that, and the fifth, you know, so those types of things could actually hinder your patient's ability to get treatment. If they've had a stroke or any head injury, those are gonna be some issues. Falls, and not necessarily a head injury, but just a fall. So that coronary catheterization, or a PTCA, which is the percutaneous transluminal coronary angioplasty, that may be one of the treatments that they receive. And then the last treatment that I'm going to add on here, and this is going to depend on what they find in the cath lab, may be a cabbage. Okay, which is a coronary artery bypass graft. And that could be a single, a double, triple, quadruple, 5, 6, 7, 8, 10 vessel process. Okay. So what is the difference between stable angina, so let me just roll this up here, and unstable angina? So let me finish the word here. So angina, oh, literally, for the love of the Lord. Seriously. All right, so here we're going to have chest pain instead of with activity or exertion. This is going to be at rest. Okay. And by the way, after your, let me just make a comment here. If you're having stable angina, then let me scroll up a little bit and over. If your patient should have resolution of symptoms, so like no chest pain, you know, after with treatment. Let me say with treatment. So what I'm saying here is with stable angina, if you stop the activity and you know, it may be a combination of all of these. They may need oxygen, and nitroglycerin and aspirin, but either way, your chest pain goes to 0. So you want to do that 0 to 10 or 1 to 10 pain scale for chest pain. And that's going to be significantly important. And then you need to identify if you're doing 0 to 10 or if you're doing 1 to 10. Because if you're still having chest pain at 1 to 10, then the patient may inadvertently receive additional treatment. So you need to make sure that you document in your nurse's notes exactly how you did the pain. Did you do a 1 to 10 or a 0 to 10 pain scale? So that way, and keep writing it on a 0 to 10 or on a 1 to 10 pain scale so that, you know, whoever's reading it doesn't make any additional presumptions. So here that it's going to be chest pain at rest, and it's going to last for greater than 20 minutes. There'll be no relief. No relief. Even though you do the same exact treatment, then nothing's changed here. So let me just roll this down. Oops, wrong thing that I rolled down. Let me go back. So all of this here is going to be the same thing. You're just going to move it over. So this is going to be your treatment. All of this here, everything of what we talked about, all the way down to the bottom. There's nothing different. Just Control Z. So let me just do it this way. And then when I scroll it down, it won't be a problem. So it's the treatment's the same. Okay. So same treatment. Here, when I say no relief, key here is lasted over 20 minutes. The patient still has chest pain. This unstable angina really is the patient having a myocardial infarction. Okay. So we're still going to do oxygen, nasal cannula 2 to 4 liters. We're still doing that. Nothing's changed there. We're still making sure that we don't hike up those oxygen saturations. We're not going to do that. Just put 2 to 4 liters. We're also going to give the nitroglycerin tablets. We're going to do our nitroglycerin IV or nitroglycerin via transdermal paste. We're going to give the aspirin chew and swallowed. And then they still will be looking at going to cath lab or potentially getting TPA or potentially having a cabbage done. So all of those things are the same. So what labs would you anticipate doing for your patient? Labs and diagnostics, and this will be for both. So that your labs, first of all, would be to make sure it's not something infectious. They're going to do a CBC. They're going to do a Chem 12 or 22, depending on what they want. They're going to do cardiac enzymes, which would be the CK MB, which is the myocardial bands. and this is actually subscripted, so let me do it the way you would see it. So CK, literally mirror, get your life right. So to be CK-MB, you'll do a troponin I. They may also do a myoglobin, and usually myoglobin is already in the body system, but you don't see it. It doesn't, the number doesn't elevate until there's actually heart injury. So they'll do a myoglobin level. So that's how you would be looking at, you know, whether your patient has angina versus a heart attack versus someone that may actually have stable angina. So that's labs. When we're looking at diagnostic tools, first and foremost, we're going to get an EKG. We're going to do that. They may also do a chest x-ray. And then we would be looking at that cath lab. I'm just going to put a question mark, question cath lab, depending on what they find, okay? And that EKG is going to be a 12 lead. They're going to have 12 different views because they're going to try to identify the different types of, you know, heart attacks, if it's on the inferior wall, the lateral wall, the septal wall, those types of things. But remember, your patients can go into heart failure with any of these areas of the heart being affected, whether it's interior, whether it's septal, whether it's lateral, does a posterior, the patient can still have heart failure with any of those. Heart blocks, bradycardia, that's usually seen with more of your anterior types of MIs. So you would be looking for, on that 12 lead, ST segment elevation. This would be if the patient's actually having an MI, it'd be elevated. If it's angina, you may see ST segment or T wave inversion. So ST segment depression or T wave inversion. Okay. The patients can actually go into different dysrhythmias like ventricular tachycardia. Is that a regular or an irregular rhythm? Ventricular tachycardia. Is that a regular or an irregular rhythm? Would you guys like leave the group?
It is an abnormal rhythm that has a regular.
Is it regular or irregular?
It is regular.
Regular.
It's a regular rhythm, but it's a lethal rhythm that we talked about last week, right? Or the week before last, so 2 weeks ago. Because I started with basic ECGs. Okay. So if you have all this here, we'll talk about, and this is kind of going backwards, and I apologize. What happened there? Hey, come back. All right, so let me just, you know, operator error here. Let me make sure. Clear this up real quick. All right, so we'll just go here again. I hit something, you know, fat finger Franny, and then I couldn't figure out what I did. So let me just. restart it and then go on. All right, so we're gonna look at risk factors. What are some risk factors for developing angina?
Sedentary lifestyle.
Okay, so let me share screen, go to the paint. So risk factors. All right, definitely sedentary lifestyle, obesity, diabetes, high cholesterol, hypertension, gender, genetics, especially if you're male. Anything else?
Smoking.
Okay, yep, smoking can cause problems. All right, so of these, which ones are non-modifiable?
Gender, genetics,
Oh, I missed one. Actually, a couple. I'm going to say diabetes type 1. Type 1, and then I'm going to say diabetes type 2. And then I'm going to add age here. All right, now finish out. These are going to be, the green is non-modifiable.
diabetes type 1, and age.
Diabetes type 1 and age, you cannot change. Okay, everything else you can fix. So let's talk about genetics. So this is more directed towards the males. Usually males have more heart attacks than women up until women go into menopause, then it becomes 50-50, and they believe it's due to the estrogen hormone, lack of estrogen hormone, that the estrogen hormone has been a protective process for women. So, so we'll take it pre-menopause. We're gonna go before the whole menopause process. If your grandfather had a heart attack and your uncle had a heart attack, so your grandfather had one at 72, your uncle had one at 52. If you are a male, can you have one at 22?
Yes.
Absolutely. So this falls on the male gene. That's why it's good to know what your genetics, your medical history in your family. And that is because if you're a male, then this will trickle down into the gene pool. Okay. So when I say I should have family history next to this. So family history. All right. Everything else we should be able to modify. Get up. One other thing that I didn't put on there is stress, but stress causes vasoconstriction, just like smoking, just like hypertension. Okay, and the smoking is from the nicotine in the cigarettes. But those things are definitely important to understand. Post an MI, they can have heart failure or have AFib. So those things are things we need to be monitoring for, like a new onset of AFib. You report that immediately to the PCP. So say, for instance, your patient is having a heart attack. It's been going on for greater than 30 minutes. They've had no relief with nitroglycerin, whether it was IV, PO, sublingual, not PO, but IV, sublingual, or transdermal, it doesn't matter which one. And the patient now goes into, you're monitoring the patient, they're admitted on your floor, and they go into cardiac arrest. So you walk in and your patient is pulseless and apneic. What's the first thing to do?
Hit the code blue button.
All right, so we have code blue button,
And then immediately start chest compressions.
and then we have chest compressions. Or what I should say, besides saying that they're pulseless and apneic, let's just say they're unresponsive. Just gonna change that. All right, so your patient is unconscious. IOUS, unconscious. What's the first thing you do?
Pulse check.
Say what?
Pulse check.
Okay, so we're always going to check the patient first. So then we pull the code blue, then we start chest compressions. So if you walk in, the patient's unconscious, you say, hey, 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 are you okay? So they'll be unresponsive. Then the first thing you're going to do is you're going to assess the patient. You're going to check a pulse and check respirations. That's the first thing. So remember, you always assess, then intervene. Okay?
What about a sternal rub?
Still an assessment.
That can be used instead of the hey, hey, you okay?
Yep, but it's still an assessment.
Okay.
So you still look, listening, and feeling. You're still assessing whether this patient is pulseless and apneic. But always assess the patient.
Right.
Don't just immediately pull the code blue button without having the assessment, because when the doctor comes in, then what's the first thing they're going to say? Hey, tell me what happened. And you're going to be like, I don't know, I pushed the code blue button. I called you guys.
For the record, I only said that first because you told me the patient was pulseless.
I know, and I realized I set you up for the wrong thing. So this is the reason why I said, let me go back. But I'm just stressing now that, you wouldn't know whether they were pulseless or not, or apneic just walking through the door. So that's why I had to, what would you see when you walk through the door? An unresponsive patient, unconscious patient. So that's why I backed that up. So that's not on you, that's on me for setting it
I've
up
seen people
incorrectly.
push on a chest and the dude's trying to fight them off of his chest.
So yeah, I mean, even if you did a sternal rub, that's the most noxious thing you can do to a patient outside of putting pressure on the nail bed with a pin. That's another way that you can check to see if the patient's responsive. And if patients don't move, even if you do a sternal rub to yourself and you do it gently, you're still going to feel a painful stimulus. That is an uncomfortable feeling to the body system, especially against the bone. So, we check that. I mean, code blue would be the next piece, but assess, then code blue. And this is why it's important, and especially for you guys as bridge students, you don't do clinicals. You have no clinicals that you're doing. You do a couple of VSIMs, right?
Yeah.
But you're not in the clinical setting. So you're kind of, even though, it's hypothesized, and I'm using that as the term, that, they're utilizing your experience, but the hypothesis is that you know these things. The truth is you don't. So when you're in clinical, especially on third level, you're kind of at a little bit of a disadvantage. So over the summer, if you're able to, if it is open, to go to the lab that you guys are doing your skills session in now to practice on your assessment skills and things of that nature. But you should have an S-bar on your patient completed by 8:30, 9 o'clock. Why? Because the physician comes by asking for a report. How's the patient's assessment this morning? any changes, and they don't want to hear you haven't gotten to it. Does that make sense? So in their mind, their patients are the most important thing. They don't care about, Dr. Green's patients. They only care about their patients. So time management is really going to be of the essence. So just kind of food for thought. I watched a very good friend of mine in the ICU literally she was lawnmowered by the surgeon. And she's wicked smart, but just didn't have the right common sense. And she's my friend. And when the doctor left, I said, and she was like a little miffed. I said, you messed that up. Why haven't you assessed the patient? And she was like, well, I really didn't have time. I said, well, why are you giving him a report on the patient that you got in report, not something new? I said, that made no sense. And she let a little pharmacy tech beat her out. That pharmacy tech was on the floor by 7 o'clock in the morning, looking through those charts, looking up information. The patient was an basically had SIADH. And the doctor asked, well, she said, it was a he. He goes, why do you think the patient got SIADH? And she was stumped. She was an ICU nurse and had been an ICU nurse for quite some time. So she should have been able to put those pieces together. So, don't get beat out by the pharmacy intern. That makes absolutely no sense. Because their whole thing is drugs, but they were trying to learn, the tricks of the trade. And the physician gave her 2 attempts. And he flat out said, you don't know this patient. And actually said, I don't want to talk to you anymore. I know the patient. I was standing right there, and I wanted to tell her sis and give her that union kick, just be quiet. So, just start working on getting your flow together, even in your own natural environments of where you're working, if you're not furloughed in anything like of that nature. Questions? So I think that finishes out all of the cardiac stuff, all the perfusion. So the only thing we would have left would be the elimination, because we're going to talk about neurogenic bladder, and that neurogenic bladder is tied to what? How do patients end up with a neurogenic bladder?
Issue with the central nervous system.
Say that again?
Issue with the central nervous system.
Okay, yeah, but why?
I guess poor sensation, knowing that it's full, or poor motor. You can't actually force out any fluid.
Okay, but why? I'm not saying anything of what you're saying is wrong, but your bladder just doesn't become neurogenic just for, poops and giggles. So I want to know why we are having the deficit.
It could be spinal trauma. It could be a brain tissue infarct.
Stroke.
Lesion.
So basically, there's some type of trauma of some nature that the individual could be having. Does that not ring somewhere around the the concern or the truth or whatever you want to call it? So yeah, your bladder just doesn't become neurogenic. Oh, you know what? I think today I'm just going to be neurogenic. It doesn't do that. So yeah, that neurogenic bladder happens for a reason. But the bladder lacks control. But it lacks control because of either a brain injury, so a closed head injury, a spinal cord injury, or because of a nerve problem. But there's been damage to the nerve that has occurred. And there's other conditions like multiple sclerosis, Parkinson's. Those are all other things that can cause a neurogenic bladder. But primarily, it's a trauma, either head or spinal cord. So here we have to now think about elimination and how we're going to get this bladder up and kicking, or basically up and working, which would mean we would have to train the bladder or retrain the bladder. So it's kind of like potty training, but it's either going to be over or underactive because of the actual injury that they've sustained. But it's either an external trauma, disease, or injury. So start looking that stuff up. So when we get to it, which will be next Tuesday, and we're going to start early on Tuesday, by the way. So I'm thinking 8:30, just to make sure we have time to cover everything of what we need. And then we'll do a Zoom session. So that way you'll be ready for the exam. What other questions you have over the last 2 weeks worth of material? What lab value gives you the best indicator of heart failure?
BNP.
Yep, it's the BNP. I was like, Lord B, I know you guys know this. What the heck is
I heard someone else say it, but they
I
were
think
very
Kim
quiet.
said it, yeah.
I haven't heard anything. I'm like, am I on this? And I keep saying to myself, are you on this call by yourself? I mean, what the heck is going on? So yeah. If you have a patient that has peripheral vascular disease, or more specifically peripheral arterial disease, and tell me what you would typically find, and say it's in the lower extremity. What would you find on your assessment?
It would be painful.
Okay, they could have intermittent claudication. Okay.
Got a slow cap refill.
They'll have delayed capillary refill. That is correct, because it is an arterial clot.
Like
The limb could be cool and pale.
Pale and cool limb. It could have ulcers on it because we have decreased perfusion. That could happen. What else? Anything else?
leg pain.
Someone did say the claudication. They did say that. Okay. If a patient has heart failure, then what should the patient be monitoring at home and call their PCP for if this happens?
Daily weights.
What kind of weight?
So 2 to 3 pounds a day or 5 pounds over a week.
Correct. So if they go from 135 to 140, and that has, that was in 3 days, that's a problem. But, you want to tell them about their weights per week. So 2 to 3 pounds per day or 5 pounds per week. And also, we want to make sure they're aware of the increase in shortness of breath at night. So that P&D, what is P&D?
Paroxysmal nocturnal dyspnea.
So paroxysmal nocturnal dyspnea, which is shortness of breath. Okay. So talking about, have you guys looked at your sensory information? That'd be a no. Okay, moving on. So make sure you're looking at those things like sleep and vision and like glaucoma versus cataracts versus macular degeneration, you know, what would happen, sleep, you know, how sleep affects folks, what makes people have insomnia, you know, caffeine, those are things to keep folks up. Usually, if you can't sleep at night, it's usually a problem that you haven't solved throughout the day. So kind of go through and look and see, hey, you know, what is it that was stressing me earlier that I may not have found a complete solution for? You don't need to find the whole solution then, but just kind of how you're going to attack the problem. And then usually after that, your body can relax enough for you to go to sleep. But, you know, you'll see people that have not been able to sleep or are pretty restless and they don't make really good decisions whatsoever. And it could be so stressful to the point that they're, you know, having diarrhea because their body is just stressed to the max. So, you know, those things are things you want to, you know, go back and look at. And how do you treat cataracts and how do you treat glaucoma if they decide to have their lens, have a cataract surgery done? You know, what will be the post-op treatment? So those dark glasses, pain medication, the optic drops that are antibiotics. So they're going to need those to make sure they don't get an infection, and they'll have to put those in on a routine basis. Usually look at the normal changes that happens with aging. So, you know, hearing starts to go, vision is usually the first thing to go. Usually night vision is what is one of the main issues that happen, and it's normal though. That's normal with aging. What is that word called? You know, that impaired night vision. There's a medical term for it.
Noctiopia?
No, but that's a good guess.
Nyctalopia? I can't pronounce that word.
Maybe I'm thinking about hearing. There's a word where you have hearing loss, not vision, but hearing loss. Starts with a P.
Presbycusis?
Presbycusis. Yeah. But I thought there was one for the eyes for some reason.
Yeah, night blindness.
Well, that's impaired night vision. It's not necessarily blindness, but things look a little hazy or fuzzy, and you start seeing more of those halos or stars with the lights. So that's usually a common thing. When a patient does have presbycusis, then you know you need to find out which ear you can actually speak in the best. And how would you identify if a patient is actually having a hearing problem? What kind of body language do they have?
Well, if it's a kid, they pull at their ear.
Okay. But if you're talking to them,
They'll lean forward.
Turn the good ear towards you.
Exactly. They're going to turn their ear that they can hear the best with towards you. So that way, you know, they can hear what you're saying. So that is something that they will do. Then you need to assess for any type of nerve conduction, maybe or nerve damage like Meniere's disease. What is Meniere's disease? How do we treat it? What types of interventions we want to talk about? So you have some things you need to look at. Talk a little bit about that. So we'll pick that back up, especially with the next Zoom session. But we're going to cover that, diverticulitis, what that is. We'll cover the neurogenic bladder, paralytic ileus, and then we'll start looking at all of the sensory stuff. So, kind of giving you some leeway of things to start digging into, OSA, which is obstructive sleep apnea. How do you know you have it? What would be signs and symptoms a patient would have, like that loud snoring, dysrhythmia problems, poor performance at work, So, you know, start looking into your skills book, your Taylor-Lynn book, your Brunner book to help facilitate that. Sounds good?
Yes.
All right. So if you guys don't have any additional questions, because you're not asking me anything, then, you know, we may have, we'll sign off for today.
I have a quick question.
Go ahead.
I'm sorry if it's too much of a question. Is there any way you can go back over I'm confused on the EKG readings, how VTAC is regular,
Okay.
but it's, I don't know, I'm having a hard time with that one.
Okay, so let's just, I'll go to a website and I'll show you how it's regular. Ventricular, listen to me.
Christy, do you come from a music background?
Say what now? Do I come from
No, I was going to ask if Christy does.
Okay.
Because if she knows how a metronome's regular, VTAC is regular like the metronome. It's just wide and ugly.
Okay.
Right?
Yeah.
That makes sense. I guess it's hard for me because I'm thinking this is not a good thing, and how is it regular?
Okay, so
You're looking at the
it's regular because you're looking at the spacing between the R waves. So the beats are in succession, but there's no difference in the distance between the beats. So I'm going to share my screen here. And I'm going to go to images. So you should be able to see my Google screen. All right, so what they mean by regular, and just, you know, make sure. I'm going to increase the size. Okay. So look at this. Can you see this beat here that I have the cursor over? Can you see this here? It says ventricular tachycardia.
Yes, ma'am.
Okay, so if I was to take a piece of paper and measure from here to here, this distance from this peak to this peak, and I would have to turn it sideways because it's lower. I can't actually hold the paper straight because I don't have a marking that's the same height or amplitude. So I'm making this bigger as well, so that way, I don't want to do that. Exit. I wanted to just roll this over. Oh, well, it's just now only good. Here we go. So I would slant my paper, but I would go from peak here to peak here. But if I measure from here to here, here to here, here to here, here to here, this is going to be regular. It would be no different than this one. So this would be my R wave here. And you can see this has a different configuration, but it's still ventricular tachycardia because it's wide and ugly. It's wide and bizarre. So what you'll see in the books, it'll say wide and bizarre. They're actually showing you 12 lead. So let me see if they will give us just lead 2. So that way we can just see it in a 6-second strip. So here's a good example. This is regular. So if you measure from here to here, here to here, these are going to be the same spacings. This one, this is lead 2 down here, is the same thing, but it's not as wide. This is a little bit narrow, but it's still wide. Okay. I'm going to skip the other ones. This is ventricular. This is saying tachycardia, but I would need to see that close up and make sure that's not V-fib. It's not chaotic. It actually looks regular, just low amplitude. But here's another lead 2 ventricular tachycardia. And if you look at these points, they're all hitting pretty much on this isoelectric line, which basically means same line. So I can measure it's, I'm gonna put one here. So it's almost 2 boxes. And if you can see here, it's right on it. So it's just about at 2 as you go all the way across. That's what makes it regular. Now, if I'm looking at ventricular fibrillation, and I just wanted in lead 2. So this here is more chaotic in its approach. So I don't know exactly where my R waves are. So these look kind of similar, but this looks different. This has almost looks like a hilltop. Then I have a pointy piece. Then I have something rounded, but it's chaotic, so it's not the same. I cannot clearly identify the R waves in this strip. Does that make sense?
Yes, ma'am, that does. Thank you.
Okay. So yes, it is regular here. This is V tac. This is V fib. It's more chaotic. So, you know, if you are sitting at the nurse's station and you see somebody with either of these two rhythms, before you call the code, you still need to assess the patient to see, you know, before you verify. Because they're going to ask, are their pulses apneic, et cetera. Don't waste your time getting a blood pressure unless the person has a pulse with ventricular tachycardia, because they can. They can have perfusing or non-perfusing. Non-perfusing means it's a CPR. If it's perfusing, that means they have ventricular tachycardia, but they still have a pulse and the heart's pumping. But that won't last for long. So eventually it's going to tap out. And then we're going to be in a full-blown code. It's going to go from perfusing to non-perfusing. So yeah, this looks like VFib. This doesn't look like VTAC. Here's another form of ventricular fibrillation. And these almost look the same, but then what is this here? All this is, you know, scraggly. So there's nothing that's regular about it, okay? So hopefully that clears that up.
Yes, ma'am.
Okay. But those are lethal rhythms. Everyone knows asystole. Can you defibrillate asystole?
No.
No, you cannot. There's nothing to defibrillate. Defibrillation is to stop these types of rhythms, these abnormal rhythms where the ventricles are taking over. When we have asystole, there's nothing that's happening. There's no electricity. There is no pump. No, the heart's not moving. So trying to now, you know, do anything with the electricity part would just be counterintuitive and more damaging to the patient. So very good question. Anything else? All right. So we'll break it for now. 8:30 on upcoming Tuesday. We'll hit out with or start out with diverticulitis. We'll do probably a case study. So, you know, get some reading done over the weekend. Then we'll do another Zoom session next Friday from 4 to 6. Get you ready for the test, and then we'll move on from there. Sounds good?
Yep, sounds
Yes,
good.
thank you.
All right, you are welcome. We'll catch up, guys. So enjoy your weekend.
Thank you.
Thank you.
You're welcome.
Thank you.
You're welcome.